Good morning. Today I will be talking about acute laryngitis. That is the acute inflammation of the larynx. Now, acute laryngitis may be classified as acute non-specific laryngitis and acute specific laryngitis. Acute non-specific laryngitis is further classified as acute simple laryngitis, acute epiglottitis, acute laryngotracheobronchitis. Let us first talk about acute simple laryngitis. The causative organism is usually an influenza virus, rhinovirus, adenovirus, or sometimes secondary bacterial infection. Predisposing factors are allergy, it may be a nasal allergy or a bronchial allergy, winters, more common in winter and spring season, vocal abuse or voice abuse, inhalation of irritants, alcohol consumption, chemical inhalations, and acid reflux. So these are the predisposing factors for acute simple laryngitis. Let us understand what happens in acute simple laryngitis. So there is hyperemia, vasodilatation of mucosa of the larynx, resulting into extracellular edema. There can be mucopurulent exudates. A pseudomembrane will be formed, resulting into superficial ulcerations, and if it is not attended or treated in time, it can further lead to perichondritis. The symptomatology, the way the patient presents will be hoarseness of voice, dysphonia, altered voice, phonesthenia, this is weakness of voice, aphonia, that is loss of voice. As it is acute inflammation, there may be associated pain in throat, painful dry cough. The same symptoms are more severe in children as compared to adults. Sometimes there may be dyspnea. Now you can appreciate the congestion. This is the epiglottis, this is the vocal folds, two vocal cords, the ventricular bands, arytenoids, and aryepiglottic fold. You can appreciate the entire larynx is congested. The patient presents with fever. There is edema of epiglottis, A-fold, ventricular bands, vocal cords, and you can sometimes visualize thick mucus secretions on vocal cords when you do a telelaryngoscopy or indirect laryngoscopy. How do we treat this simple laryngitis? You have to avoid all the predisposing factors. Irritants are to be avoided, cold atmosphere is to be avoided, avoid alcohol, voice rest has to be taken, humidification by steam inhalations, mucolytic agents to loosen the mucus and liquefy the thick secretions, then analgesics, cough suppressants, dextromethorphan may be used, and broad spectrum antibiotics if there is associated secondary infection. Second condition is acute supraglottic laryngitis, also called as epiglottitis, because as the name suggests, it is basically inflammatory condition of the epiglottis. The causative organism is Haemophilus influenzae type B. It is more common in pediatric age group. There is severe cellulitis of epiglottis, AE fold, there is congestion and edema of the mucosa, inspissated mucus secretions may be there, there will be obstruction of laryngeal vestibule, preventing effective coughing to remove secretions. Patient presents with sore throat, difficulty in swallowing, pain in swallowing, odynophagia. The voice is muffled as if you are trying to speak with a hot potato in your mouth. So it is a hot potato voice, which is a classical symptom of epiglottitis. Some patients complain of foreign body sensation in throat. There may be, if the laryngeal edema is a lot, there can be inspiratory stridor. On investigating these patients, the WBC count will be raised, polymorphonucleocytosis. On X-ray of the soft tissue neck lateral view, we will see the thumb sign. X-ray chest may also be done. A throat swab and blood culture is done, which may reveal H. influenzae type B. To confirm, a flexible laryngoscopy may be done. Now, this is a classical picture of cherry red epiglottis. You can see it is so much edematous. The sharp outlines of arytenoids, AE folds, and this is the glottic area which has become so narrow and edematous. Now, this is a classical sign called as thumb sign. The epiglottis, which is sharp and linear, it becomes swollen, edematous like a thumb. So, this is called thumb sign, which is seen in X-ray soft tissue neck lateral view. In children, you should differentiate stridor and consider acute laryngotracheobronchitis, laryngeal diphtheria, angioneurotic edema, laryngeal edema secondary to retropharyngeal abscess, or acute tonsillitis. Treatment will be you have to hospitalize these patients. IV antibiotics are to be administered. The choice of antibiotic can be ceftriaxone given in the dose of 75 milligram per kilogram per day 12 hourly, or cefotaxime 50 to 100 milligram per kilogram per day 6 hourly. Humidification, oxygenation, steroids, IV hydrocortisone 100 milligram may be given. In severe cases where there is stridor and dyspnea, oxygen saturation is low, endotracheal intubation or tracheostomy may be required. Coming to the third condition, acute laryngotracheobronchitis. As the name suggests, there is inflammation of the larynx, the trachea, and the bronchus. So, it is acute inflammation of larynx, lower respiratory tract involving subglottis, trachea, and tracheobronchial tree. Etiology is myxovirus, parainfluenza virus, H. influenzae, pneumococcus, hemolytic streptococci. Now, this condition is seen below the age of 5 years, starts with upper respiratory tract infection, fever, cough. There may be biphasic stridor as the larynx and the lower respiratory tract both are involved. In severe cases, there may be air hunger, patient feels short of breath, or the cry is weak, the Patient is not able to cry, and there may be a seals bark cough. Now let us understand how this acute laryngotracheobronchitis behaves if not treated adequately or in time. At the onset of infection, there is submucosal edema, which causes mechanical obstruction of subglottis. There can be mechanical and secretional obstruction. There is edema of the mucosa as well as secretions in the tracheobronchial tree, further causing blockage, resulting into inspiratory stridor. This will result into prolonged inspiratory phase with wheezing. There is air hunger, hypoxia. The child may be restless because of hypoxia. There may be cyanosis or hypercapnia, acidosis. Patient becomes stuporous, quiet. Facial expressions may be expressionless, and acidosis is there. There can be reduced cough reflex, reduced air entry, and there may be a respiratory failure. So this condition has to be identified quickly and treated adequately. To diagnose, few investigations may be done. X-ray, neck, AP view. This will reveal the steeple sign. X-ray soft tissue neck, lateral view. This will reveal subglottic narrowing. X-ray chest may show pneumonic patches because of the involvement of the bronchus. WBC count will be raised, and blood culture will identify the causating organism. Now, this is a classical picture of a steeple sign. You can see in a normal individual, the subglottic, this is the vocal cord shadow, and the subglottis is quite wide. But in acute laryngotracheobronchitis, the subglottis becomes edematous and there is narrowing, and it looks like a steeple of a church. Treatment will be this is an emergency. Hospitalization in pediatric ICU. Patient requires humidification, mucolytics, oxygen has to be administered, IV fluids, IV antibiotics, and steroids. In severe cases, endotracheal intubation or tracheostomy may be required to secure the airway. Let us have a look between two conditions which need to be identified and what are the differences between them. Acute epiglottitis and acute laryngotracheobronchitis. The organism H. influenzae type B, and in this parainfluenzae virus type 1 and B. The age group acute epiglottitis 2 to 7 years, older age, and acute laryngotracheobronchitis, younger age group 3 months to 5 years. Site of obstruction is supraglottis, and in this obstruction is at subglottis, which is the narrowest part in children. Flu symptoms are absent. In this, the flu symptoms will be present. Onset is abrupt in acute epiglottitis and gradual with laryngotracheobronchitis. Fever will be high grade in acute epiglottitis and low grade in tracheobronchitis. Toxic, this is non-toxic. Cough will be absent. Barking, seal bark cough is there in laryngotracheobronchitis. Dysphagia is severe, usually absent. Drooling will be present in epiglottitis. It is absent. Family history of URI absent. there will be family history of URI in laryngotracheobronchitis. X-ray will show thumb sign in lateral view, and laryngotracheobronchitis, there will be a steeple sign. Now coming to the specific inflammation of specific acute inflammation of the larynx. So this is laryngeal diphtheria, often seen secondary to partial diphtheria. Causative organism is Corynebacterium diphtheriae. The age group is usually 10 years below. Now, the incidence of laryngeal diphtheria and partial diphtheria is reduced because of extensive immunization schedule in pediatric age group. When the patient presents with laryngeal diphtheria, the onset is insidious. Patient may have hoarseness, coughing, inspiratory stridor with cyanosis, and intercostal drawing with recession of chest wall. There is a marked cervical lymphadenitis, which may be bilateral. Signs, the features are same as partial diphtheria. There is superficial necrosis of epithelium of the larynx. Membrane may be seen over the vocal cords and vestibule area. Stridor will be present. Cervical lymphadenitis will be present. Any form of membrane seen in pharynx or larynx should raise a suspicion of diphtheria. Now, on laryngeal examination, you can appreciate the entire larynx, the epiglottis, vocal cords, glottic area, ventricular bands, all are covered with a membrane. This is the classical feature of laryngeal diphtheria. Investigations which we need to do in such cases are CBC, complete blood count, ESR, throat swab is taken, which is grown on Loeffler's serum slope or blood agar, and the causative organism Corynebacterium diphtheria is isolated and studied. Urine shows presence of albumin. Flexible laryngoscopy may be done. Treatment will be prophylaxis, that is by way of immunization. Isolate, as this is a contagious disease, the patient needs to be put in isolation ward. He has to be hospitalized. Antidiphtheric serum has to be administered. 40,000 units to 1 lakh unit IV diluted in saline, which is given in 1 hour. Half is given intravenous and the half of it is given intramuscular. Antibiotics like crystalline penicillin, 6 lakhs units, 6 hourly may be required. In cases who are allergic to penicillin, erythromycin may be another antibiotic which can be used. In cases of severe stridor, again, intubation and tracheostomy may be required. Bronchoscopy also may be required to remove the secretion and the crust from the larynx and subglottic area. To summarize the salient points, acute epiglottitis, causative organism H. influenzae, there is a cherry red epiglottis, and on X-ray there will be thumb sign. Acute laryngotracheobronchitis, causative organism is parainfluenza virus type 1 and 2. There can be fatal airway obstruction, subglottic narrowing, and steeple sinus seen on X-ray. We should know the differential diagnosis between laryngotracheobronchitis and epiglottitis or supraglottitis. Laryngeal diphtheria, Corynebacterium diphtheria is the organism. There is a membrane formation on vocal cord, antitoxin, antidiphtheric serum, 20K to 1100K in a single dose or split dose, half IV and half intramuscular, and tracheostomy if there is respiratory distress. Thank you.